Welcome to the Guilbault Girls Show, where you will have the opportunity to hear from mothers, fathers, siblings, and individuals themselves about their journey of living with a disability. I know, it's called Guilbault Girls, but we have a bonus for you as we get the Guilbault boys to interview some of the dads and siblings to get their perspectives too. We'll also have special guests from time to time to share the many resources that are available to those living with a disability and their families. So get ready to laugh, smile, cry, maybe even get a little angry when you hear some of those stories of their day-to-day struggles. But let's not forget their many triumphs. As they say, it takes a village, and if it weren't for our village, we wouldn't be where we are today. So join us. Hello, and welcome back to another episode of the Guilbault Girls Show. I'm your host, Karen Guilbault, and today's guest is Dr. Edward Kuwera, Assistant Professor of Ophthalmology and Fellowship Program Director in the Division of Pediatrics and Adult Strabismus at the Wilmer Eye Institute of the Johns Hopkins University. So welcome. Thank you so much for being on the show today. I really appreciate you taking the time out.
Thank you, Ms. Guilbault. It's a pleasure to be here.
You are welcome. So tell us, what does your primary focus involve?
So I'm a specialist in strabismus. That is really my expertise, complex forms of strabismus, which is a misalignment of the eyes, frequently associated with double vision in adults, and in children, they don't get double vision, but it is visually threatening to have things like strabismus. So that is my main expertise, and I do adjustable surgery for both adults and children in terms of strabismus. One of the few people in the world that do this for children, where after we fix the eyes and straighten them, after the surgery is done on the same day, we can take a look and make sure that the eyes are where we want them to be. And if they're not, we can do an adjustment in the recovery area on the same day so that the person leaves with the best possible outcome. So that's my main expertise, but I also have a particular interest in things like nystagmus, amblyopia, and cortical visual impairment. Nystagmus is a shaking of the eyes that can happen for various reasons, and amblyopia is a weaker brain-eye connection from an eye that's either not being used or doesn't see well for various reasons. And cortical visual impairment is something that I developed an interest in after working with many kids that have come to my clinic with this diagnosis, but with a lot of uncertainty, both from the parents' end, the patient's end, and our end. CVI is a condition that is not very well understood, even among ophthalmologists. And that's why it's a really team-based approach to diagnosing and treating CVI. It's a multidisciplinary approach in order to target every aspect of how the brain coordinates the body, including the eyes, of course.
Yeah, and we'll get into a little bit because I'm going to share a little bit about Faith too and her story and how long it took for her to finally get the diagnosis. So I read in your bio that you are an award-winning educator and member of the Pediatric Eye Disease Investigator Group, the PEDIG. Can you tell us a little bit more about that?
Absolutely. So PEDIG is a multi-center group where my boss actually created this with his colleagues, Dr. Michael Repka, and this group studies different pediatric conditions and formulates ways to best diagnose and best manage different conditions with basically peer-reviewed and really scientifically based studies. So, for example, things like strabismus, like exotropia, where the eyes go out, there are studies ongoing to what's the best way to treat this. Is it patching? Is it an eye drop? Is it surgery? Is it observation? Glasses? There are so many approaches to different eye conditions, and there hasn't been enough studies done to investigate all of the approaches in treating these conditions. And so this group basically looks at all different eye conditions and looks at how we can best manage each condition.
Awesome. So you also have additional expertise and interest in other areas of ophthalmology. Can you share some of those with us?
Yes, absolutely. So I'm involved in AR and VR, augmented reality and virtual reality headsets that are going to be used to diagnose and treat patients with different eye conditions. We're working with a neurologist with that, and I'll expand upon that a little bit later.
Okay.
neurologists and biomedical engineers at Johns Hopkins that are really it's an amazing institution because it allows us to have collaborative efforts with so many different disciplines. And Johns Hopkins, as you know, is probably one of the best biomedical engineering centers in the country, and one of the best neurological centers in the country. So to have that kind of expertise, as our colleagues, provides us an environment that really can brings us to the leading edge of science. And I think it's really a blessing that I get to work in a place like this where you get to see what the future is going to be like before anyone else does.
That is so awesome.
Besides that, I'm also working on several projects. I like to enhance trainee education. So education is a big part of my sort of extracurricular work, if so to speak. So teaching and education are another aspect of my interest that I'm basically focus on. So I'm also involved in creating an ophthalmic anesthesia curriculum, as well as training people of all different levels in medicine. So fellows, residents, medical students, as well as even college and high school students.
That's awesome. So I really wanted to hone in on the cortical vision impairment because, I feel honestly there's not enough education and awareness about it, which kind of goes back to what you were saying too. So, but before we do, I just wanted to kind of share a little background for folks in regards to faith before we dive in, just to kind of tell how my experience was as well. So I was on bed rest with Faye for 42 days in the hospital and had her at 31 weeks premature. She was in the NICU just under 2 weeks. The day that they released her from the hospital was the day that the neurologist said that she had PVL, periventricular leukomalacia, and that she had 85% chance of having cerebral palsy. Then at 6 months, by 6 months old, she was diagnosed and we saw many specialists. She was in therapy and she always had issues since birth where we questioned her vision. And she had, and I'll probably not pronounce some of these right, but so she had, but they said she had bilateral strabismus, myopia in both eyes, alternating, how do you say that?
Esotropia. Esotropia.
Okay. And bilateral optic nerve atrophy. So you could clearly see that her eyes were crossing and she wore the glasses. I remember the glasses, it was almost like bifocals. Like they were very like those thick, old time school glasses, remind me of my grandmother.
Yep.
And then we did the eye patching and we did different eye exercises, if you will, to help strengthen those muscles. The doctor at the time, he was cautious. He didn't want to do the surgery just in case of, overcorrecting. As he said, he didn't want to Mickey Mouse it, is what he said. And then, but over time, her eyes did straighten out. However, she was still struggling a lot with the processing part of what she was seeing. In school, she struggled a lot. They even had the Maryland School for the Blind come out in and test her. And that was back in 2011 to make any recommendations. So the teacher at that time for the visually impaired who performed her assessment said that she didn't have a visual acuity issue, but a brain acuity issue. So overall, she didn't feel that Faith had CVI, but had some tendencies that can be accommodated in the same way a student with CVI gets accommodated. She at that time she was going to Cecilton Elementary, which I can tell you, oh my gosh, they were amazing. Every single year from pre-K up until 5th grade, there's not one thing that they wouldn't do or try for her. And then we ended up hearing about vision therapy, Delaware Vision Academy. So we ended up signing her up for 24 sessions. So every week from Maryland to Delaware, we drove over, and it did help, but it got to a point to where it really couldn't go any further. And they did a lot of testing and they said that, that it was a brain issue. And then it wasn't until later on when we moved to Harford County and I was told off the record by another vision teacher that came to work with her, she had 8 out of 10 markers for CVI. And then of course they can't diagnose it, but you need to go see a neuro-ophthalmologist. Now remember that word, folks, because it took so long, for anybody to kind of fill us and cue us in on that. And so when I went in to see Dr. Repka, and he's awesome too. And, I ended up, I was going through all my paperwork and I found the MRI from when she was born. And so I brought that in, and he, as soon as he saw that too, he clearly said that she had CVI due to the, significant amount of damage that she had to the optic nerve alone, not including all of the long list of documentations that we've had throughout the years. So, and that opened her up to where she could go to the Maryland School for the Blind. So it was 10th grade when she started going there. So all this time, I mean, yes, she did have accommodations. They did the best that they could. But we could have had that so much, prior
Agreed.
to that. So
Agreed.
yeah. So then in the article you had sent me on the CVI, it states children with CVI display a wide range of visual deficits, including decreased visual acuity, impaired visual field function, as well as impairments in higher order visual processing and attention. Together, these visual impairments can dramatically influence a child's development and well-being. Given the complex neurologic underpinnings of this condition, CVI is often underdiagnosed by eye care practitioners. Again, brings me back of all the, and she does, and she does have, like, she couldn't even perform the was it the visual acuity testing or whatever, but
Yes.
so yeah, so I just want to kind of give a backstory to tell people, make sure you go to a neuro-ophthalmologist. So with all of that being said, so here's my multi-level question for you. So you can break it down however you want and expand on whichever, but if you can share with the listeners what CVI is, how it presents, what the different stages are, how it affects individuals, and or what are the signs to look for, what the steps are to diagnose CVI, and what accommodations are helpful. Now, I know that's a big parameter, but I know we're going to be crossing over and everything. So take it away.
Absolutely. So first, yeah, it was very disappointing to hear that Faith had such a delay in receiving this diagnosis, because with the diagnosis of PBL alone, periventricular leukomalacia, that is a condition that absolutely affects the optic pathways. They travel right within that area, the periventricular white matter. And so children that have that diagnosis almost definitively have CVI. And so already there was a miss there, unfortunately. The other, again, unfortunate miss is that you had heard brain acuity. And so that's already saying that the brain was the problem. Why didn't they transition it to that diagnosis? I'm not sure. I honestly don't know. But the best people to see for this diagnosis are either pediatric ophthalmologists or pediatric neuro-ophthalmologists like Dr. Michael Repka. However, that being said, depending on the practice, depending on the training that the person has had, there may not have been much experience in CVI. Mm-hmm. And if there's a lack of experience in CVI, it's very difficult to know what to look for or what to recommend also. And so in addition to just understanding CVI, you probably know that there's so much that goes into evaluating CVI that an ophthalmologist visit, which is like 10 minutes, is simply not enough to get the information that you need for a child that has such a complex history. And so it is a little bit unreasonable for ophthalmologists to have to be able to give recommendations off of a small visit like that. And so I want to make it really clear what the role of an ophthalmologist is in CVI. I happen to have a little bit more expertise in this because I'm interested in it, but it is not the expectation of the general pediatric ophthalmologist to know it to the level, let's say, that I know it or that you know it.
Right.
And so the goal of the ophthalmologist is to determine if the visual system, the way that the person is seeing, is basically it's out of proportion to their findings. So, for example, a person who has just, let's say, a very mild cataract in the eye, which is a blurry lens or a cloudy lens. It's very mild, and anyone else could see through that perfectly. And you see that in a child, and that this child, for whatever reason, cannot seem to navigate the environment. And all you see is a cataract. But then you get a history of there's been some maldevelopment of the brain. Right, that out of proportion vision with just a small eye finding versus what they show you is what classifies a person to having cortical visual impairment or cerebral visual impairment. It's that the visual parameters are way lower than what you would expect for what you see in the eyes. The eyes look great, but for some reason they don't see well. Now there's a spectrum of that because Faith did have optic atrophy. She shows an eye problem too. So she does have an eye problem, but she also has a brain problem, and the brain problem is worse than the eye problem. And the vision that you see is worse than what you would expect just simply from the optic atrophy. That again is how you diagnose cortical or cerebral visual impairment. And that diagnosis is a clinical diagnosis. It's not based on just one or two things. It's a picture. It's an entire picture based on the history, like prematurity, for example, or having some kind of neurological history that's very common with prematurity, or some kind of neurological injury or syndrome. Those are things that can lead to having worse vision than expected based on on eye findings. So who to go to? Pediatric ophthalmologist or pediatric neuro-ophthalmologist. How it's diagnosed, it's a multidisciplinary effort, and the ophthalmologist's role is to tell the other team members what does the child or what does the person see? What is their vision? What can they see? Colors, contrast, what's their acuity? Do they need glasses? Is there any eye problem? And then it's up to the rest of the teams to kind of manage or rehabilitate what's there. And so places like Kennedy Krieger Institute, they have such a great pediatric team that works on all aspects of their health, from motor coordination to cognitive issues. They're a fantastic team, and they spend hours on these patients evaluating how do they interact with their world? What do they do with objects that are in front of them? What do they do with people that are in front of them? How do they navigate a dark environment, a light environment, an environment that has obstacles in it? And that type of evaluation is critical in cortical visual impairment. And that aspect of things we don't get to see as the ophthalmologist. I don't see what things are like, for Faith in her regular day-to-day world, at home, in school. And so places like Maryland School for the Blind, they have free resources where they send teachers to your home or to your school so that they can evaluate the person in their natural environment and see how things are, see how things can be improved or adapted for that person. And so that's the general sort of how to look at CVI. Now, when you start to get into all of these parameters of what to expect, what to manage, what to recommend, there is such a wide variety of presentation. And I'm going to give you some examples of what I see. There's everything from the child that doesn't seem to have any problems at all. They're doing incredible, and you really can't tease out anything significant, other than maybe the parent might say sometimes something's just off with their vision, and I don't really know why. It can be that subtle of a problem versus a child that really can't do anything other than just kind of sit there or lay there. Some kids have such serious conditions that they can't do anything but just kind of look around, and they can't follow a target. They won't look at lights, and their eyes are totally fine. So there's a huge spectrum, and it's very hard to be able to diagnose the severity of CVI in a really young child as well. So a lot of evaluating and diagnosing CVI and bringing up recommendations are based on gathering information over time. So the younger the child is, the longer it'll take us to know what the person really needs. Because I do evaluate children as young as like 3-4 months of age that are already suspected to have a problem. And that is very difficult for me to tell the parents at that age what to expect. They're so young. There's so much time for change. There's also so much time for improvement because the brain is so plastic meaning very flexible, at such a young age, that you may not have major deficits if they get older. One of the things that we actually see a lot from CVI is that you see improvements. You almost always will see improvements in the child because there are ways that the brain can reorganize its structure to support vision. But it does need to be rehabilitated. And that's sort of the part that I think more ophthalmologists need to be aware of the subtleties that can be rehabilitated. And again, we'll go into that a little bit more later. So let's say in terms of diagnosis, it's looking for vision that seems out of proportion to their eye findings. And then it's a lot of history from parents. We want parents to look for things like clutter. Does clutter seem to overwhelm the person? And clutter is a very, very telling sign of a brain issue or a neurological condition. People that have great vision but have a neurological condition are very sensitive to being overwhelmed with visual information. And so school is one of those places, unfortunately, that is very visually overstimulating. And for learning purposes, teachers like to make things fun. They'll show a child that needs to know what the alphabet is, right? They'll show you the whole alphabet. There's animals that match with each letter. And it's really cool like that, that it's interesting for a child to see all these cool things in the board. But for someone who has CVI, the strategy of teaching them has to be very different, where you cannot show them a bunch of things and you need to show them just one thing at a time, isolated so they're not distracted. And some of the things I'll show you later will go over why that is so important to reduce clutter. And so hearing about clutter or being overwhelmed very easily with visual stimulus can be a sign of CVI, especially if everything else seems pretty good. Easy distraction, easily, easy distractibility is another sign for possibility of CVI. Again, given the proper history. For example, it goes with clutter. You have two objects and you want the person to look at just one, and if you got two things there, they might just keep wanting to look back and forth between the two, and it's an involuntary thing. So a lot of parents also don't realize that the child's behavior is involuntary. They can't actually do some of the things that you want them to do, especially in an overwhelmed situation. Again, there's so much for me to branch out into that it's hard to keep this organized, but I'm trying to keep it focused.
You're fine.
Clutter, okay, is really important. Easy distractibility. Changes in floor. So, for example, a child that seems to have a lot of difficulty stepping from a smooth floor to a tiled floor. I hear that a lot also, and that sensitivity to this, what seemingly is a very benign change in flooring. There's no change in elevation. It's just texture. That is another signal that maybe there could be something that's neurological here, not just vision. And even more subtle things now. I like to use examples because it's the best way for parents to understand. I like this example a lot because it was just so telling for the parent when it happened. There was an interaction between a 6-year-old girl and her mother where there was a suspicion of CVI, and the mother was not sure, like, how to explain why she felt that there was something off about her vision. But the child frequently wouldn't look where she wants or doesn't seem to see things right in front of her. And so because of this suspicion, I asked a very specific question at that point. They were laughing and joking a little bit. So at that point, I asked the child, what is mom doing right now with her face? And mom was smiling. They were laughing together. So the child accurately said, mom is smiling. And then I asked, yeah, that's correct. What does that mean that mom's smiling? And that the child was lost. And she didn't know how to answer that. And it was then that the mother understood, oh, this is not really, it's not so much vision, but it's understanding what to do with your vision. That is the problem. So CVI, a lot of the issues stem from processing the information. They can see what they need to see, but then what to do with it is the hard part. And that is very difficult to figure out. That is why I always tell parents, have a journal, write down the little things that you think are weird or strange, that don't make sense. Write it down, because there's probably a reason for it, and we can figure it out together. And that'll, again, be based on some of the images that I'll show you later for the future of CVI. Okay, so classifying and sort of grading CVI. This is something that is, again, more of the vision teachers like Roman Lancy. I think you've met her, Christine Roman Lancy. So she has developed the sort of treatment protocol for CVI, and that is based on how severe the problem is. So for the ophthalmologist, I think that the what we should be looking at and what we should be telling the parents is what phase the child is in for CVI, what phase 0, 1, 2, or 3. And then the vision teacher or the rehabilitation specialist can use that information to say, oh, okay, this child's phase 1, let's do these therapies because this is phase 1, or phase 3, let's do these therapies. So a kind of, again, this is a very simplified summary of how to look at the phases. Phase 0, the child cannot do anything. They don't respond at all to any stimulus, just no response at all. Phase 1, there is a response. So you shine a light in the eye and there's a reaction. Oh, something's there. Or you move an object in front of them, they'll take a look. So there's just a response. That's phase 1. Phase 2, there is more than just a response. There's a little bit of interaction with the object. So, for example, you show a cool toy to the child and they'll look at it and they'll actually track it and they might even reach for it. There's some purpose behind that movement and that sort of stare. That's phase 2. Phase 3, there's even more interaction with that object. So, for example, an individual comes by the patient, they smile at the person's tracking the individual, smiles back. That is phase 3. That shows that this child can not just see what's going on, they can also follow it, they can also interpret what is going on with the person's physical sort of emotion, for example. So we should look at children and be able to figure out what phase they're in, recommend that to the parent, and then the parent uses that information to rehabilitate what is left over. And of course, the ophthalmologist will treat any eye conditions that they do see. For example, strabismus, which Faith had, glasses, which Faith had. You still need to optimize those things and then rehabilitate the neurological components after vision is optimized. Now, I wanted to say, even if a child with CVI does not seem to need glasses, I like parents to get them used to glasses, wearing sunglasses, wearing a hat, having something on the face so that they know that it's okay to have something there, because glasses are almost universally helpful in patients that have neurological conditions, simply for the fact that a changing focus is already difficult for them. Kids that have neurological conditions, especially things like CP, cerebral palsy, there is a difference in their motor tone, their muscle tone, their control of the body. That includes the eyes. For us, we have a very robust system that allows us to change focus in many different distances. We can look far away, intermediate, and close, and our eyes will change focus very easily. People that have neurological conditions don't always do that very easily. And the best way to understand that is adults that are older that need reading glasses. They can't focus up close after a certain age, and they need to put on reading glasses to really make things clear up close. We lose that ability to focus as we get older, but people that have neurological conditions may already have a deficit there, and glasses can help ease that discomfort. And not just ease that discomfort of focus, but also magnify things. And that's another part of CVI that is related to clutter. Kids will like to hold, not just kids, but people that have CVI will like to hold things really close to their face. And part of doing that is reducing the clutter that's surrounding that object so they can really pay attention to just the details of that one thing they want to look at. And so in addition to reducing the sort of clutter around that object, it also is probably easier for them to see it because it's bigger. So for anyone with vision impairment, always let them hold things wherever they need to hold it, whether it's in front of them, to the side of them. Let them hold it wherever they want to, and then we can use special glasses to change where they're holding it if necessary. So, for example, a child that has CVI and their eyes shake, they may have a good position where the eyes don't shake a lot. Let's say when they look up, their eyes are very still. And then when they start to look down to read, their eyes start to shake a lot here. That's very uncomfortable to have to look down to read all the time, right? So we can use special lenses that bring the world up or bring the world down or move the world side to side so that they can look straight ahead, but look at whatever it is they actually want to be looking at without having to move it into a special position. Yeah. So again, lots of little subtle things that we should be looking at or thinking about in CVI. I wanted to take a pause here and see if there's anything along that list that I should expand upon.
No, I think you did great. You explained everything very well. I wanted to share, there was two things with face. So, well, one, she has a hard time like looking when she's talking to you. She always has to look to the left. Like even
Mm-hmm.
like when sometimes when she's like, watching TV, she'll be kind of looking to the left.
Mm-hmm.
And then so I had cut my bangs a while back. They're now starting to grow in, but I cut them, and she kept telling me that she didn't like my hair, right? So I'm like, "Oh, thanks," the way she was saying it, right? So but then I later on figured out why. Because my hair was always one length, and then a lot of times I'll have it pulled up. She can see my face. Now
Uh-huh.
I have bangs, and she has a hard time seeing and understanding like my expressions.
Ah.
She finally was able to tell me why she didn't like me with bangs. So I thought that was interesting. And just like if we're coming out of places, again, like another example, like if you're coming out, like you have all the, again, kind of like clutters also, but when there's a group of people and she's coming out in a crowd to try and spot me out, but of course if she hears my voice, then she knows and she follows the voice. And then also she'll come out, a couple times we've come out of church, and we go out into the hallway, and there's a lot of people, and my husband is bald. So she's went up to people before thinking it was him because
Mm-hmm.
he was bald. So it's interesting to kind of watch, the different nuances, if you will, that she has done over the years.
Mm-hmm.
But yeah.
And that's a
So
very subtle feature that I'm
yeah.
I'm so glad you brought that up. Emotional recognition is something that can be very difficult for children that have CVI. And so parents will sometimes unnecessarily get upset at their child for not seeming to understand them, but they really can't. It's not their fault. And so it's important. I'm so glad this came up. It's so important for children that have CVI or suspected CVI that the parents change their wording. Change your wording so that it's not necessarily a visual component to what you're talking about. As an example, there's something right in front of the person or the child, and they're not looking at it. It's right in front of them, right below them. Okay, and so the parents are like, look down. It's right there. Go pick it up. It's right in front of you. Look down, and it's not working. The child's just like they don't know what to do. Instead of saying look down, put your head down, move your head down, and pick that up. Something that's not visually but more motor. Move your head.
Yes, move your head.
That's
Yeah.
it. It's different. Same with looking to the right or left. Some kids can't, if with the neurological condition, they can't look left or right. So you tell them to look to the right, and they can't. You got to tell them turn your head to the right, and then
Yes.
that will sort of click.
Yes, absolutely. Absolutely. 110%. Yes. So after talking with good friends of ours whose son also sees you, again, we were going to Dr. Repka for a long time, and they were real excited, and we're like, oh, we have so many appointments down in the city, we're like, if we can get anything closer, and so they had told us about you. So we went, so we got to see you for the first time. Absolutely love you. You can
Thank
like
you.
just your demeanor and just like your passion behind it, and like just talking, getting down on her level and talking and explaining things to her, and like you could, it totally shows. So we were grateful that we switched you. Love Dr. Repka too. He's awesome too, but you were
Oh,
great. And you're closer.
thank you.
So I was really, really happy that that they told us about you and that we came. So our biggest question to you was, and someone with cortical vision impairment, are they considered legally blind? Because I honestly didn't know. Like there's been times in forms we had to fill out, asking that. And I'm like, I have no idea. So of course, come to the experts and ask you guys. So you explained it to us. Can you explain to the listeners what those guidelines are?
Sure. It's There's a simple guideline and there's more complicated stuff. The simple guidelines for being legally blind is that your vision is 2200 or worse, and it cannot get better with any treatment. Glasses, contact lenses, any sort of assistive device does not get the vision better than 2200, which is usually that big letter E that you see. So if they can't see that, or they're seeing worse than that, that is considered legal blindness. Another definition of legal blindness is the person has less than 20 degrees of their visual field. So they've got a small tunnel, for example, and nothing beyond that. That can be considered legal blindness as well. But it's so hard to just use those two parameters for someone who has a more complicated visual problem. You need to take it into you need to take the whole picture into context. And Faith, of course, does have 200 vision in her left eye, I believe, and 2125 in her right eye. So technically, from a purely acuity perspective, Faith has better than legal blindness in the right eye, technically, with just pure vision. But then you look at her visual field, and she actually has a very constricted visual field. And we say constriction, but it may not just be a constriction. It could be pieces are missing as well, not just a nice circle. It could be chunks of things that are just missing. And so if there's less than 20 degrees of visual field in general, that is a definition of legal blindness too. So we need to take everything into consideration. So just because a person is not 2200, she may be 2020, but she has a small field, that is still legal blindness. So it is a combination of things that the pediatric ophthalmologist will sort of determine for the person.
I also found it interesting when I was there, when they had showed me because before I had gotten into you, when I was with the one lady, and she was showing me the screen and her eyes, and it was interesting to see really like how it started, because I was always in my mind and from what I, because sometimes appointments go so quick and everything, you don't have everything written down. I was always under the impression that she had no peripheral vision on her left side, right? So, and I knew she didn't have depth perception. But when we went in and she showed me the eye and how the dark circle like went around it, and she said how it started in 2017. It started in the left eye, and you can see kind of along the years from 2017 until now how it started going. But then the right eye started going, but then the right eye was actually more affected than the left eye. I'm like, wow, I never knew. Like, so it was eye-opening to actually see that graph and have you guys like explain everything around. Like it opened my eyes to kind of what I was looking at, if you will. It made more sense to me. Again, that education piece that you have and you hone in on, I absolutely love, because you have such a way of explaining stuff to where we get it. If that makes sense. And Faith
is so important.
And Faith was so she's like, she loved you. She's like, oh, well, I'm writing this down, I'm writing that down. And she's like, well, he told me to write this down. So he's like, she's doing the text to speech in her notes. And then she's like sending me text messages, and she's like, we see him in 6 months. Right. So it was it was pretty cool. You definitely connected with her. So it was pretty awesome. So I just want to say thank you for that.
I'm so glad. It's important for patients to understand their condition so that they can so that the treatments make sense also, and they know what to look for. That's really important. And I realize that in our busy schedules as physicians, many of us don't have the time to do that. But it's important that we try, because it's the best way to really care for a patient, is having them understand what's going on. In my opinion, that's the best way to care for a patient. They fully understand and are aware of the treatment that you're going to be going through together.
Yeah, absolutely. So what does the future look like in terms of treating neurological conditions such as CVI? And I'm going to go ahead and I know that you are going to share your screen. And you know what? I don't know if I gave you, do you have permission to share it?
Let me see. I cannot right now.
Okay, let me go ahead. Multiple participants. Okay, try now.
Got it. Yep, it's good. So I also wanted to, there was one other comment that I wanted to make on sort of the future of CVI. I'll get back to that in just a second. But
okay, yeah.
Basically, the future is going to be a lot of imaging. Imaging is going to give us information about how we can best help kids that have CVI. This is an example of an imaging technique called functional MRI. And what it does is this MRI looks at the brain's activity, and it can specify what parts of the brain it wants to look at. In this case, it's looking at the occipital cortex, which is what we see with. It's the visual part of the brain. And it can map out the activity of this part of the brain. In row A, this is a normal patient with a very kind of robust filling of this area with the blue and the yellow. This corresponds to our visual field. Our eyes and brain interpret things upside down and reversed. So the lower part of the occipital cortex is associated with the top of our visual field, and the top part of the visual cortex is associated with the bottom part of our visual field. Now you can see that in a patient that has CVI, there's just this is less robust of this coloration. And you can see that the yellow is maybe a little bit better than the blue. And
Yeah.
so looking at this map, you can already start to say that this patient will most likely have a problem with their visual field on the bottom. And that is a problem because our world is looking down, reading, walking, everything is down. And so this is a patient that you need to make sure that they can navigate properly. And you spend time on optimizing their vision below below the horizon, basically for
Right.
them.
Right.
This is fMRI. There is another kind of imaging that's also really, really new, and this article here highlights it very well. It's called HARDI, high angular resolution diffusion-based imaging, and this is a type of MRI that looks at how the connections of the brain are, how robust the connections of the brain are. And so you can see that in a control patient, this patient's healthy with no brain history, very robust connections. It's a very nicely filled picture here. With PVL, which again is so classic for having cortical visual impairment, you can see how much thinner and less filled up and less robust the wiring of the brain is here. In hypoxic ischemic encephalopathy, kids that have, that are born with insufficient blood supply to the brain can develop specific locations of damage. And notice that if this brain has significant damage here, the frontal lobe, but look at still how robust the connections are. Yet this PVL, this area over here, this enlargement of the ventricle caused such a change in the entire brain versus this big area that you can see that's a problem, didn't really do much to the overall connections. And so, CVI is something that can be this diverse. And having imaging like HARDI can tell us where we should be looking to support the person. This is another angle that looks at some of the connections of the brain. And specifically, there are two main streams of vision. We call it the dorsal stream and the ventral stream. And it's basically our naming things, our ability to name things and our ability to see things in space and recognize where they are in space relative to us. So there's the object and spatial awareness, and then there's naming things. And so these two pathways correspond with those two streams of vision. The ILF over here is involved with naming things, object recognition, emotional recognition. The top band over here is associated with spatial orientation. So in patient B, you can see that this person is going to have much more of a problem with spatial orientation or navigating their environment or knowing where things are relative to them, versus this person in C, which will probably have compromise in both naming things, recognizing things, and spatial awareness. So being able to map out the connections of the brain and how robust they are can give us this information that we can use to help solve or help find solutions and target specifically what the person needs. This is another example of another area that people don't think about as also being associated with vision impairment. This area that connects these two pathways that we just went over, the IFOF. It's involved with emotional perception, verbal and nonverbal semantic cognition, visual attention, and eye movements. And so kids that can't look where you want them to most likely have a problem here. And we can see that in this patient with CVI1, there's like nothing there at all. Versus CVI2, there's a little bit of a connection here. So you would imagine that this patient in CVI1 is going to have much more difficulty recognizing faces and emotions than person in CVI2. And so you need to work on that specifically for CVI1. And so that's basically what I wanted to share in terms of the future for diagnosing. And now what about the future for treatment? And this is still a long way to go, but this is where my colleagues and I, the neurologist that I'm working with, Dr. Kamar Green, who is basically developing an AR VR device, augmented reality, virtual reality device that has eye tracking, and it can map out the patterns of movement of the eyes. And so we can use these devices to first figure out what is the person looking at? What is their pattern? And use that and analyze it to come up with a solution for them. So, for example, a person has a lot of difficulty looking to the right, and this device is mapping out. They always just look to the left. They don't really see things to the right. Well, we know we can support them on the right side. Then we can use special glasses, or even use the virtual device to maybe highlight things on the right side or move things from the right side over for them. So there's the sort of diagnostic point of these devices, and then there's the treatment. And so I really love VR because I think that you can project a world for a child that is otherwise very uncomfortable in your office, or they're very scared of you and you can't get an exam from them. So instead, you have them wear this device where they can be in a really cool room or a really cool world that they like, and you can track their eyes while they're in that world. You can show them things that you want them to see, and you can use that to teach them. You can teach them what is an apple and just present an apple and the word apple or something like that, so that they can make those connections. You can also provide an environment that they're comfortable for learning. If they don't want to be, if they're scared to be in, say, a doctor's office, we can project a world for them that's fun, and then I can test things while they're in the office wearing this AR device with, maybe cool things in front of them that I don't see, but they see it, and it makes for a better experience for them. And so there are ways to use these devices not just for diagnostic purposes, but for treatment purposes. Kids that have amblyopia or strabismus, their eyes are not seeing well. Well, you can use the device and sort of change contrast so that one eye sees better than the other, and you can force the weaker eye to get stronger. There are already devices like that exist, and we can implement these technologies into a universal device that can do everything from diagnostics to treatment, and sort of give an experience to a person that we otherwise can't with the real world. So that is the future of treatment for CVI and neurological conditions.
That's really exciting. That's very exciting.
Very cool. Very exciting.
Love it. All right. So before we wrap up, is there anything else that you would like to share, or any advice that you would like to give?
Yes. The most important part of treating CVI and dealing with CVI is finding the right people first, finding someone who can provide that diagnosis, and then finding people who can rehabilitate what's necessary to be rehabilitated. Please remember to always reduce clutter for people that you suspect that have CVI. For purposes of learning, you never want things to be too busy. In situations where, let's say, you're struggling with a child navigating their environment, they have a hard time crossing the street. They have a hard time in the mall when it's really busy. Well, you can use strategies to isolate things for them, distract them in a different way. So, for example, you're crossing a busy street, you can have the child, instead of looking at the street and not knowing what to do, focus on mom's leg, focus on mom's foot, and just follow mom's foot as she's walking. Forget everything else around. Obviously, they're going to have to learn to integrate that information eventually, but if they can't function at that moment, guide them by isolating and sort of having them focus on just one easy thing. And then eventually they'll learn how to navigate more difficult environments on their own with sufficient practice. So distraction is really important. I'm sorry, could I share my screen one more time?
Absolutely. Go ahead.
There's one other thing that I forgot to show you, which talks about that actually. And this is another study that was done to look at how vision impairment and cortical vision impairment affects patients that are in basically low distractor sort of situations versus high distractor situations. And so as an example, this is a VR headset where a person was to find a specific object in the middle of the box, and in a low distractor sort of box, someone who's normal, of course, has no problem identifying the target. Someone with vision impairment, like let's say a cataract or a retinal problem, they'll still focus in the general area, but of course they don't see it well. Someone with cortical visual impairment, you can see that they get distracted, right? They'll look around. They don't just focus on the target there. When there's a bunch of things around, they actually will move beyond the areas of interest. They go way beyond even someone with vision impairment. Now, when there's a high level of distractors, lots of cool things in the box, it does worsen vision impairment, absolutely, but also cortical visual impairment. You can again see that the distractibility increases the size of this area that they're looking at. This is similar to like going into a mall or crossing a busy street. In low distracting environments, someone with vision impairment and cortical visual impairment can still generally stay focused where they need to be focused. As soon as you introduce a bunch of people now, look at how far across the visual field this person is looking with CVI,
Yep.
all around. Even
Yeah.
someone with visual impairment doesn't go that far. And so, very important to take into account clutter and reduce it as possible in these situations.
Yeah. Wow, that legit is eye-opening. Like,
Mhm.
I mean, like, wow, that's crazy. Wow.
Yeah,
So
it's a really fascinating topic that requires a lot more work and investment from people who are interested. We need to learn more about this so that we can better help these kids.
yeah, absolutely. Absolutely. So, as a token of appreciation for being a guest on our show, I gift all of them with a My Intent token, and I hand stamp a word into a token and I put it on a keychain or bracelet. So I had shared with you the flyer. Would you be willing to share what your word is and
Yes.
why?
Absolutely. The word that I prefer is kindness, and that's something that I think the world is lacking. And it's the way that we should approach every interaction, regardless of whether I'm interacting with my friend, a stranger, a patient, a family member. I treat everyone the same. I treat them like family, and I'm sure you probably got that experience with me. That's the way I like to practice, and that's the way I wish the world would run, with kindness.
Love it. I love it. Well, thank you so much again for taking your time out and being on the show, because it is truly is. It's all, it's about networking and building those connections and working together to bring about the awareness. So I appreciate your time, and I'm glad that you're Faith's doctor.
I wanted to thank you and Faith also for getting this information out there, for interviewing people who are involved with kids that have disabilities, because it's a very underserved area and there's not enough information out there. So, with your permission, I also would like to host this podcast on my website at Johns Hopkins, so that we can share this with the world.
Absolutely. I'll get you the RSS feed, I think it's
Sure.
called.
Thank you.
Absolutely. No, I appreciate it. Okay, so everybody, make sure you tune in next time for another episode of the Guilbault Girls, and have a great day. Bye-bye. Thank you for joining us as we spread awareness through our personal stories and the many resources shared. You can help us by joining our village simply by sharing our show with the masses. You can also become a supporter of the show by clicking on the link in the show notes. Your funds will allow us to keep sharing these valuable, heartfelt stories and resources. Be sure to subscribe to our Guilbault Girls podcast and YouTube show, and don't forget to follow us on Facebook and Instagram at Guilbault Girls.